Hi friends, today we will be discussing about an approach to thyroid nodule. Whenever we get a thyroid nodule on palpation or imaging, how will we approach further for the diagnosis? This will be we will be discussing today. Thyroid nodules are common, but thyroid malignancies they are rare. We should always remember that thyroid nodules are very common, but malignancies are rare. And aggressive cancers are extremely rare. Prevalence of palpable thyroid nodule is 5% in women and 1% in men. Visible in it is a thyroid nodule is visible in up to 67% cases on sonography. Thyroid nodules are incidentally detected in 16 to 18% of the patient when they undergo neck CT or MRI, and in 25% cases they are detected in the CT chest. Half of the adults over the age of 60 years they have thyroid nodule, and thyroid malignancies they are rare, and here usually 5 to 10% cases of the nodule the patient can have malignancies. Thyroid nodule is basically a discrete lesion within the thyroid gland that is radiologically distinct from the surrounding parenchyma. Non-palpable nodules detected on ultrasound or other anatomic imaging studies are termed as incidental lomas, or we can say incidentally discovered nodules or incidental lomas. Whenever we get thyroid nodule on palpation or during any imaging, what further we need to do? If the nodules are more than 1 centimeter, they need evaluation, and if nodules are less than 1 centimeter, they may require evaluation if there is suspicious sonographic findings. I will be discussing about the sonographic findings in the thyroid nodules, and if we get nodule less than 1 centimeter but with the suspicious sonography findings, these nodule needs to be evaluated. And if the patient has thyroid nodule with lymphadenopathy and the patient is a high risk factor, as he might have childhood head and neck irradiation, or when the thyroid cancers are seen in first or third degree relatives of the patient. In such cases, even though the nodule is less than 1 centimeter, we have to do the evaluation. Whenever the patient of thyroid nodule reports us, history and physical examination are very important. We have to ask about the childhood head and neck irradiation history, total body irradiation for any bone marrow transplantation, family history of thyroid carcinoma or the thyroid cancer syndrome in the first degree relatives, and rapid nodule growth or any history of hoarseness. These are the important points which we must consider while taking the history of the patient with thyroid nodule. In the examination part, the physical findings which suggest the possibility of the malignancy, they include the vocal cord paralysis, cervical lymphadenopathy, and the fixation of the nodule to the surrounding tissue. All the patients with thyroid nodule, they should undergo serum TSH level, radionuclide scan, ultrasound of the neck, 18 FDG PET scan, and FNAC for further evaluation. Thyroid ultrasonography should be done with the evaluation of other cervical lymph nodes also. And the advantage of thyroid sonography is we can easily make out whether that is a true nodule or not. We can get the size of the nodule, pattern of the ultrasound imaging characteristics which I discuss later, cervical lymphadenopathy, whether it is present or not, position of the nodule, whether the nodule is cystic or not. With the thyroid sonography, we will be able to know whether it is a nodule or a cyst, size of the nodule, various patterns of the patterns seen in the thyroid nodule, associated cervical lymphadenopathy, and the position of the nodule. Important ultrasonic findings which we see in the thyroid nodules are the microcalcifications, nodule hypoechogenicity as compared with the surrounding thyroid or the strap muscles, irregular margins, whether the shape of the thyroid or the nodule is whether the nodule is taller than the wide. These are the important points uh, which we see in the sonography findings, and they help to differentiate whether the patient has a risk of malignancy or not. Various sonographic patterns and the risk associated with the malignancy is when the patient has a cystic thyroid swelling, it is very benign. The risk of malignancy is less than 1%, and when we say very low suspicion, it is very chances of malignancy are less than 3%. When the patient has spongiform, cystic, partially cystic, and spongiform features. I will be discussing this in my next slide. When we say low suspicion, the chance of malignancies are 5 to 10%. When patient has hyperechoic, solid, regular margin, isoechoic, solid, regular margin, partially cystic with eccentric, solid area. When do we say intermediate suspicion? When hypoechoic solid regular margin or hypoechoic solid regular margins. High suspicion findings, they have high risk of malignancy, that is 70 to 90%. When patient have microcalcification, these are the small microcalcifications. Hypoechoic with irregular margins, hypoechoic taller than wide, and these are the important findings in various these are the various important ultrasonic findings which help us to differentiate whether the patient has a low suspicion, high suspicion, intermediate suspicion, and what is the risk of further progression to malignancy. In ultrasound characteristics, when do we say the patient has high suspicion? High suspicion means 70 to 90% chances of getting into malignancy. When the high suspicion findings are when the thyroid nodule is solid hypoechoic component with in partially cystic nodule with one or more of the following feature. Means one thing is the nodule should be hypoechoic with these features: irregular margins, microcalcification, taller than wide, disrupted rim calcification are evidence of extrathyroidal extensions. The intermediate suspicion characteristics which are seen in ultrasounds, they are the nodule will be hypoechoic with smooth regular margin but without microcalcification, without extrathyroidal extension, without taller than wide shape. So these microcalcification, extrathyroidal extension, taller than wide shape, these features will not be seen in the intermediate suspicion findings. So the nodule will be hypoechoic with smooth regular margin but without microcalcification, extrathyroidal extension, and taller than wide shape. So low suspicion ultrasound findings will be isoechoic or hyperechoic solid nodule or partially cystic nodule with eccentric uniformly solid areas without microcalcification, irregular margins, extrathyroidal extensions, and taller than wide shape. So these features will not be there in the low suspicion. The nodule will only be isoechoic or hypoechoic solid nodule or partially cystic nodule with eccentric uniformly solid areas. But these microcalcification, irregular margins, or extrathyroidal extension, these will not be seen in the low suspicion. These findings are very characteristics of the high suspicion features. So when do we say very low suspicion in ultrasound findings? When we get spongiform or partially cystic nodules. Spongiform or partially cystic nodule without any of the sonography features described in the low, intermediate or high suspicion patterns. So we have discussed that if we only get cystic nodule, that is a benign, it has a chances of malignancy is less than 1%. Very low suspicion has chances of malignancy less than 3%, and these nodules are spongiform, partially cystic or spongiform feature, partially cystic or spongiform features. And similarly, the nodule which ultrasound findings which show low suspicion, that nodule will be hyperechoic solid regular margin or isoechoic solid regular margin, and they have chances of malignancy 5 to 10%. Similarly, the ultrasound findings if show intermediate suspicion, they will be hypoechoic solid regular margin in thyroid nodule, and they have chances of malignancy of 10 to 20%. And ultrasound findings show high suspicion when the nodule have microcalcification, hypoechoic irregular margin, hypoechoic taller than wide, and the chances of malignancies in these cases are more than 70 to 90%. Thyroids, basically it is a thyroid imaging, reporting and data system. It refers to any of the several risk stratification system for the thyroid nodules or the lesion. And ACR thyroids means ACR is American College of Radiology. I once again repeat, this American College of Radiology thyroid, it is a reporting system for thyroid nodule on ultrasound basis, ultrasound findings basis. Basically, this thyroid system uses a standardized scoring system for reports, providing users with recommendation for when to use fine needle aspiration or ultrasound follow-ups of a suspicious nodule, or when to safely leave alone the nodule that are benign or not suspicious. So here we see that we have taken 5 things into consideration, that is the composition, echogenicity, shape, margin and echogenic foci, and we have given different points to them. Suppose in composition, if thyroid nodule is cystic or almost completely cystic, we give 0 point. If it is spongiform, we give 0 point, and if it is solid or almost completely solid, we give 2 points. Similarly, for echogenicity, whether it is anechoic, hyperechoic, hypoechoic, very hypoechoic, we given these points as 1, 2, 3. And when wider than tall, 0 point, taller than wide, we give 3 points. Similarly, if the smooth margin, we give 0 point, ill defined 0 margin, extrathyroidal extension, we give 3 points. Similarly, echogenic foci, when there is macrocalcifications are there, we give 1 point, and when we get punctate echogenic foci, we give 3 points, and we add points from all categories to determine the thyroid level. If we add all these points, means composition, echogenicity, shape, and depending upon these level, we further divide. If we get 0 point, then it is a thyroid level 1, so it is a benign, no FNAC is required. And if we get 2 points, it is TR2, it is a not suspicious, no FNAC required. If we get 3 points, then it is a mildly suspicious, mildly suspicious, we need to do FNAC if the size of the nodule is more than 2.5 centimeter, and follow up if it is more than more than equal to 1.5 centimeter. If we get 4 to 6 point, then it is a moderately suspicious. FNAC is required even if the size is more than equal to 1.5 centimeter, and follow up is required if it is more than 1 centimeter. And if we get 7 points or more, then it is a TR5, and it is highly suspicious. The FNAC is required even if the size is more than equal to 1 centimeter, and follow up is required if it is more than equal to 0.5 centimeter. I hope it is understood now. So the fine needle aspiration will be required or will be required for diagnosing if the nodule is more than 1 centimeter with high suspicion sonographic pattern, and FNAC is also done if nodule is more than 1 centimeter with intermediate suspicion on the sonographic pattern, and if nodule is more than 1.5 centimeter with low suspicion, and nodule more than 2 centimeter with very low suspicion sonographic patterns. So as the size, even if the size of the nodule is increasing and it has a low suspicion, we do FNAC. These are the 4 important features which are required for the FNAC to be done. FNAC of the thyroid gland, it is not required if the nodule that don't meet the above criteria which I discussed in my previous slide, and if the nodule is purely cystic nodule, we don't do FNAC. Bethesda system for reporting thyroid cytopathology. It established a standardized category-based reporting system for the thyroid fine needle aspiration specimens. This system says that every thyroid fine needle aspiration report should begin with one of the 6 diagnostic categories, the names of which are shown as non-diagnostic or unsatisfactory, benign, ATP of the undetermined significance or follicular lesion of undetermined significance, follicular neoplasms or suspicion for a follicular neoplasm, suspicious of malignancy, and the malignant. So these are the important. So every fine needle aspiration cytology report of the thyroid nodule should at least begin with one of these 6 diagnostic categories, that is 1, 2, 3, 4, 5 and 6. So if we see that if the FNAC is suggestive of non-diagnostic or unsatisfactory, the risk of malignancy is 1 to 4%, and here we have to repeat FNA with ultrasound guidance. Similarly, if we get benign lesions, the risk of malignancy is still 0 to 3%. Clinical follow-up is required. And if the FNAC is suggestive of ATP of undetermined significance or a follicular lesion, once again repeat, if FNAC is suggestive of ATP of the undetermined significance or follicular lesions of undetermined significance, the risk of malignancy is 5 to 15%. We have to repeat FNAC. And if the FNAC is shows malignant cells, the chances of malignancies are 97 to 99%. We have to do near total thyroidectomy. And if it shows suspicion for malignancy, chances of malignancies are 60 to 75%. We have to do near total thyroidectomy or the surgical lobectomy. I hope you can read this slide. In ultrasonically confirmed thyroid nodule, if the FDG PET shows uptake within that nodule, it shows the increased risk of thyroid cancer, and in such cases the fine needle aspiration is recommended even for those nodule if it is more than 1 centimeter. diffuse FDG PET uptake in a conjunction with the sonographic and the clinical evidence of chronic lymphocytic thyroiditis does not require further imaging or the fine needle aspiration. And last, this is the algorithm for evaluation of the thyroid nodule. I have taken it from the Harrison. So whenever the patient of thyroid nodules reports us, and if thyroid nodule is detected by palpation or imaging, get a clean his history and physical examination and do TSH levels. If TSH levels are low, we have to do the radionuclide scanning. And if radionuclide scanning shows hyperfunctioning nodule, then we have to evaluate and treat the hyperthyroidism. Means if the radionuclide scanning shows hyperfunctioning of the nodule, we have to further evaluate and treat the hyperthyroidism. And if the TSH levels are high or normal, then we need to do diagnostic ultrasound. And if the levels of the TSH were low and radionuclides show that nodule is not functioning, we have to do the diagnostic ultrasound also. So if we do diagnostic ultrasound of the thyroid gland, and if the nodules are detected on ultrasound, do FNAC based on US imaging features which I discussed, like the sonography features of high suspicion, intermediate suspicion, low suspicion, very low suspicion. And even I discussed about the various indications for FNAC. And then we have to do the FNAC of the thyroid nodule. And as we know that the FNAC is done, we do the recording as per the Bethesda system. And if it is non-diagnostic, we have to do the repeat ultrasound guided FNAC. And even if it is non-diagnosis, we have to closely follow the patient, or the surgery can be done. And if the result of the FNAC is malignant, we have to do pre-op ultrasound for lymph node assessment, and we have to do the surgery. And if the FNAC report is suspicion for PTC, we have to again do the pre-op ultrasound for lymph node assessment. PTC is papillary thyroid carcinoma. And if FNAC shows follicular pattern or follicular neoplasm, we have to consider the molecular testing, and surgery is indicated if we have pre-operative ultrasound for lymph node assessment. If there is ATP of the or follicular lesions of undetermined significance, we have to do repeat ultrasound guided FNA or consider the molecular testing, and surgery if indicated with pre-op ultrasound for lymph node assessment. And if we get benign lesions, we have to just do the follow-up. This was about the evaluation of the thyroid nodule or approach to a patient with thyroid nodule. I hope I made it clear in a simplified way. Most of my slides are from Harrison's. Please do read Harrison for better understanding for the approach to thyroid nodule.